So in management of ovarian cyst in pregnancy, so I would like to say ovarian cyst in pregnancy is a common, about incidence about 0.1 to 1%, 8%. So it's mean 1 in 1,500 to 30,000. So there's a clinical significance of NSMS, especially during the pregnancy. Especially first is a corpus lutein cyst, in which the corpus lutein cyst is produced by the progesterone to support the pregnancy. Okay, and if we remove the corpus lutein cyst during the pregnancy, it increase risk of miscarriage because there is no supportive. And okay, the cyst is highly vascular and it will resolve after 16 weeks. Okay, and then it will resolve, it will regress up to 8 weeks, actually starting at 8 weeks. Okay, so the next is a follicular cyst. It's a physiological method of the follicles, or a fail of involution of the mature follicles. The diameter is about 2.5 to 6 centimeter, and conservative management is advocated, and it will resolve after 16 weeks. About the hemorrhagic cyst, patient may present with sudden onset of abdominal pain, and if the patient was stable, conservative management is advocate. Usually it's a benign. It's difficult to distinguish between either benign or malignant, right? And then at the same time, it's difficult to use the color Doppler because there is no vascularity in the color Doppler. There is no vascularity within the clots, right? The fourth one is a hyperstimulation of ovaries, or we call it the ovarian hyperstimulation syndrome, OHSS. So it happen in patient who underwent the infertility treatment, especially during the induction of ovulation, right? The incidence is about 3 to 8%. It's a self-limiting and require the supportive management for while awaiting the resolution of the OHSS. Surgery is indicated once the torsion or rupture happen, because it's very difficult if we going to the surgical, right? Because it's highly vascular and liable to damage, very fragile. Okay. At the same time, the fifth one is a hyperreaction of luteinalis. So it's the ultrasound picture is similar to OHSS, but the difference is there is no induction of ovulation prior to the cyst. Okay. Patient may present with a virilization about 14 to 25%. The sixth one is a luteoma. It's very rare, the benign condition. It luteinized the stroma cell replace the ovarian parenchyma. So at the same time, the female will become the pregnant woman may present the virilization signs, and then if the pregnant woman and then if the fetal is a female, it about 50% the fetal will become virilization after delivery. Okay. Other benign condition like metastatic teratoma is a most common diagnosis after 16-week pregnancy, and is if the dermoid size less than 5 cm or less than 6 cm, or asymptomatic, we may go conservative. And then if more than 6 cm, more than 6 cm or equal to 6 cm, there is risk of ovarian torsion. It's about 27 to 30% high risk. So at this moment, the MRI is useful to identify, to distinguish either the benign or malignant condition. In the malignant condition, ovarian malignancy, so ovarian, so like this dysgeminoma, which is a common happen, especially in during the pregnancy. But bear in your mind, it is a good prognosis and sensitive to chemo and radiotherapy. About the borderline ovarian tumor like epithelial ovarian tumor, we may the cystic lesion with the malignant feature, and but without invasion of ovarian stroma compared with the malignant. Other benign conditions like para ovarian cyst or fibroma or penetrated uterine fiber is one of the differential diagnosis. Otherwise, if the patient presented with the acute abdominal pain, we may rule out any appendicular mass or mesenteric cyst or diverticular mass. Okay. From the history wise, you must ask the patient about the symptom, about the acute abdominal pain symptoms. There is maybe a torsion, rupture, or hemorrhagic. Okay. And then about the abdominal distension, there is any compression, any pressure symptoms like urinary, acute urinary retention or constipation. Okay, about previous gynae history also important. Maybe the mass is present before the pregnancy. Okay, is it benign or malignant? If patient is a history of ovarian malignancy, so we may bear in your mind there is a risk of increasing recurrence. Okay, so careful monitoring this patient. Okay, if history of ovarian malignancy pregnant. Okay, on general examination, that we may palpate any abdominal mass and characteristic of the abdominal mass. So we did the VE especially to identify the NSMS. But bear in mind, you must do careful VE because during the VE you will irritable the uterus and cause the preterm labor or recurrent miscarriage. Okay. The first diagnostic tool, the important diagnosis is ultrasound. Ultrasound examination is superb. Okay. Is it adequate for assess the ovarian mass and characteristic of the tumor and the size? And if we monitor the size, so if size increase more than 20% from the baseline before the follow-ups, is highly suspicious of ovarian malignancy. The iota score is important to distinguish between is a benign or malignant condition. The sensitivity is about 91%, and specificity about 93%. It's high sensitivity for iota score, right? And then color Doppler may help us to identify is highly vascular or it's a benign or malignant. In the malignant, we can see the highly vascular ovarian mass. Sensitivity is high also, it's about 86 to 91%. Okay. MRI and CT scan is useful to increase the accuracy of diagnosis. But in pregnancy, we prefer MRI because there is useful is a for first better tissue composition characteristic and fat tissue, and we can assess the metastasis. And at the same time, it's safe because it no radiation exposure to the fetus compared to the CT scan. Okay. About the tumor marker, when we talk about tumor marker, in our mind, CA125 is the main first tumor marker for ovarian cyst. However, it will raise during the pregnancy, and because it also produced by the decidua by placenta. It's difficult to interpret. So some studies says if the CA125 more than 100, 110, 112, right? So it's a cut off point of CA125 in the pregnancy. It is useful to monitor CA125 in patient who has history of ovarian CA. Okay. About the LDH, is increase during dysgeminoma, right? So however, the pregnancy not affect the LDH level. Okay. Alpha fetoprotein is limited use during the pregnancy because it will increase and raise also in pregnancy. At the same time, it will increase for patient who diagnostic of neural tube defect, especially alpha fetoprotein. Okay, human epididymis 4 is a new one, right? The new one is when we talk about this, the study say it's a more accurate, more sensitive and specificity compared to CA125, and then it can help us to differentiate between benign and malignant in the pregnancy. But however, the study says the varies of the values in the pregnancy. So still under study about the HE4. So that's why we use the ROMA, including the HE4, right? Alright, about the RMI score, it may be useful for postmenopausal women, but in pregnancy it's limited use. IOTA score is useful or determined between benign and malignant. ROMA score is also limited use because the A125 and H4 increase during pregnancy. In terms of management, the conservative management is for simple cysts like asymptomatic functional cysts. Follow-up is required to the large cyst at around 40 to 60 weeks. Intervention may delay until the 40 to 60 week to allow the spontaneous resolution of functional cysts. Okay, to prevent any surgical volatile cyst. Okay, in the benign condition of the ovarian cyst, we can manage as conservatively if patient asymptomatic. Aware to patient there is a risk of overretorsion in pregnancy. Patient decision is important between the risk of intervention and conservative management. Okay, management based on the patient decisions. Right. There is a rule of fine needle aspiration under ultrasound guidance. So well tolerated and a few complications in no hospitalization required. Okay, cyst aspiration is a meant for functional cyst only actually sebenarnya. Useful in relieving the pain and reduce the size of and reduce risk of torsion. Okay, the issue is a increase there is study say it's a high rate of a cyst recurrent, about 40%, 30 to 40%. Okay, alright. So about the surgical management, surgical intervention, there is a few indication. Right, first is acute abdominal pain, as we know, is a torsion abdominal or ruptured cyst or hemorrhagic cyst. And then ovarian malignancy, suspicious of ovarian malignancy feature. For this time, you MRI is benefit to determine whether it's a malignancy or benign. Rapid growing of the ovarian cyst, right, mass. And then cyst more than 10 cm because we afraid there's a risk of more obstructed labor, okay, during the third trimester. Okay, about the approach actually it depend on about any patient that we suspect of malignancy mass. Okay, we may consider the age of the patient and the required fertility preservation and desired fertility also is a important points. Gestational age, which is first trimester, second trimester, and this is explained based on trimester also. The parity, okay, and the important part is stage of the disease is early stage or advanced stage. In the early first trimester stage, we may deliver during second third trimester with the cesarean section together with the operation. However, in the advanced stage of malignancy, we may offer termination of pregnancy if the early trimester. Okay. In the surgical approach, that is safe. The popularity approach nowadays is a laparoscopy, and sure is safe because it's a less blood loss, improve the visualization of pelvic organ, and reduce risk of uterine irritability. But there is a controversy issue about the carbon dioxide because the hypercarbia increase the fetal acid base disturbance and reduce risk of uterine blood flow. At the same time, it reduces the placenta blood flow. The study shows pneumoperitoneum 12 to 15 millimeter mercury not affect the uterine placenta flow, and then it not cause the IGR of stillbirths. Okay. At the same time, however, we may bear in your mind there is potential risk of uterine injury during the various needle incision or primary port incision. That's why we may approach by Hussein technique or Palmer technique to consider to reduce the risk. Okay. However, the laparotomy is preferable in the patient who we suspect of the ovarian malignancy. The approach is based on the uterine size, both benign or malignancy. Okay, the availability space, intraoperative space, okay, the gestational age, that's the all the important part. Okay, in conclusion, the assessment is important to decide our management. Alright, thank you. Stay tuned.